Two patients are suspected to have committed suicide in the space of a week at a mental health unit at the Waitemata DHB in Auckland. That's prompted the DHB to launch an independent external review of He Puna Waiora inpatient unit next to the North Shore Hospital. Dr. Kevin Cleary is the acting director of the DHB's mental health services, and he joins me on the phone now. Dr. Cleary, this must be absolutely devastating for staff and for the families.
Hello, Lisa. Yes, it is. We extend our deepest sympathies to the families of those patients. We're very, very sorry for what has happened. This unit, He Puna Waiora, has been open for 4 years now. And in those 4 years, up until this week, we've had no inpatient suicides, though we've had hundreds of patients successfully treated in the unit. And we've had two happen in a short space of 5 days or so. And for that reason, we have agreed to undertake an overarching inquiry into the unit and its functioning.
What can you tell us about these deaths? How far apart were they?
They happened this week, so over a space of 5 days.
Yes, but can you be more specific between the gap and the deaths?
5 days, Lisa.
Apart?
Yes.
Okay, so did you make any immediate changes after the first death?
We did. We have made a number of changes on the unit immediately, and we have made some more changes today.
What are those changes?
So the changes basically have been around the environment. I'm not going to go into great detail about that. But
have you removed bathroom doors or doors?
We have removed ensuite bathroom doors. Yes, we have. And in addition to that, we have put in extra staffing, because we know from our experience this is very traumatic for patients on the unit, for staff, and for the families of our patients. And we want to make sure that we can reduce the risk as much as possible.
Did these deaths occur at night or during the day?
They occurred in the late evening.
Okay, so what checks were happening at that time of the evening?
An inpatient mental health unit runs 24 hours a day. So the checks are the same through the day. There are regular checks on patients on their whereabouts in the unit. And then
How frequently? How frequently?
It varies from patient to patient. So the lowest level of observation would be once every hour. And then there are checks every 15 minutes and up to continuous observations, all depending on the clinical condition of the patient.
So in the case of these two patients, what monitoring regime were they on?
They were on a monitoring regime on the ward of being checked regularly by nurses. I'm not going to give you the precise detail of when they were seen. That's really for...
So you can't tell me how many, at what intervals they were checked? Were they on 10-minute checks?
I know when the patients were checked, but what I'm saying is that is for the inquiry to look into.
Okay. Let me put it another way, Dr. Cleary. Were all the checks that were scheduled to be done on these two patients done as they should have been?
And again, I'm saying I'm not going to go into details of what was happening on the ward on the day. There were regular checks being undertaken, and that is for an inquiry to establish as to whether the checks were done appropriately or not.
All right, well, let's just talk about general systems then. In the evening, let's say a patient needs to be checked every 10 minutes. Is that through a window, or do you physically enter the room, talk to the patient, or cite the patient?
So if the patient is on hourly checks, then they are seen face-to-face every hourly. If they are on more regular checks, then the patient is normally spoken to. But, of course, if the patient is asleep, they're not woken up for the checks.
Okay, so not woken up, but if a patient was asleep of an evening, would you go into the room? Or would you check them through a window, is what I'm trying to establish?
Okay, so both may happen. The patient may be checked through a window, or the patient
Even
may
a high-risk patient would be checked through a window?
As I was saying, they may be checked through a window, or then the staff nurse may go into the room to do the checks. It depends upon the risk involved. And also, you have to understand that it is quite intrusive. Someone coming into your room and disturbing you every 10 minutes. Patients have a right to dignity and care like all of us. They're not different from us. And it's very intrusive to wake someone up every 10 minutes to talk to them.
So it's obviously a balance between privacy and preserving life, though.
It is always a balance between privacy and dignity, and keeping a safe eye on what is happening on the ward.
So, do you know if you had a full complement of staff on at the times these deaths occurred?
At this point, I can't answer that question.
Because you don't know, or you don't wish to?
Because that is something for the review to look at.
It is an incredibly serious issue and of extreme public interest, and these are not questions that pry into someone's privacy. Staffing levels, were you at full staffing capacity when these two patients died?
Again, what I would say is that all of these things will be looked at by the inquiry. I think that it is important that we have been very transparent about this. I know from my experience in patient safety, and I've worked in patient safety for 15 years, that transparency is key. And that for that reason, we have invited two senior clinicians from outside of the organisation to come in and do a comprehensive, thorough review.
And I understand that, but Dr. Cleary, families who have entrusted their loved ones to you right now, who may be in that unit too, they will want to know that they can trust the level of care that you are giving. How can they have any confidence in you and that unit?
And I understand that, and we have spoken to all of the patients on the unit, and we have spoken to their families, and have explained to them what has happened and what we are doing, and what we're doing to make sure that we have reduced the risk. We have ensured that there is appropriate staff in place and that they have the right senior support. And we've had psychological counsellors come in and talking to the patients and staff on the unit.
So how many more staff than usual have you boosted numbers to?
We have boosted numbers appropriately for the unit at this point in time. And obviously...
And what's that?
And that is, we have assessed the risk of the patients on the ward, and we have added the number of staff that we feel is appropriate.
You have had issues with staff shortages before. Beds have been closed down in 2017 and 2016. So, can you tell us how many more staff you've brought on?
I cannot tell you how many staff we brought on. I am confident that we have brought on the right number of staff appropriate to the risk situation that we're facing at the moment.
And again, did you have the right number of staff on at the time these two people died?
And again, I would say that is something for the review to look at.
All right, I thank you for joining us this evening. That is Dr. Kevin Cleary, who's the Acting Director of Mental Health Services at Waitemata DHB.